another dynamic surgeon, and he's going to talk to us about again about anterior vitrectomies and how to do an optic capture.
Thank you, Priya. I think it's wonderful to be in your course year after year. And since, as you said, posterior vitrectomy is the order of the day, if you have a lot of vitreous gushing into anterior chamber, but since my topic is anterior vitrectomy and I will capture, I'll limit myself to that. Now, this is a case of a high hypermetro, basically a high hyper 20 who had a trap plus phaco was planned for. You can see I'm starting this. I mean, this is a shallow chamber. I have starting with the IOP of 50. I'm feeling that the chamber is becoming shallower as time goes because I have kept a vacuum quite high around 600 and the aspiration. I have got my IOP higher. I've got it around 55, but still I'm feeling that, well, I'm not very happy with the dynamics. That is because there's an anterior chamber, and there I realized that I've caught the posterior capsule and there is a small rent there. And as you can see, this is the moment when you have to be alert. How you go, as Partha said, take a small drip. I mean, you cannot stop your surgery, but then definitely all your senses are alert. And I'm doing a bit of clearing of the lens matter, as my friend philosopher guy Dr. Amar has shown us the IOL scaffold in these sort of cases, and Dr. Chitra also showed. Now this is the lens which I am dialing it, putting it over the sulcus, and since most of the I could create a differentiation between anterior and the posterior and take off, I have reduced my IOPC. Again, this important that when you do that, you don't want that lens. If you have a bigger opening, the whole lens might stick inside. So get your IOP down at that moment, and that's what I, in spite of from 55 got to 30. I've got almost all my, and then I'm going the bimanual ISC. With one hand I'm pushing the lens that is at the scaffold, and I'm taking out the cortex as much as possible as I'm going. See, the iris has already plucked my incision, and at every time I come out, I'm putting the viscoelastic so that I don't lose that. I mean, I have realized that I have not got vitreous, but at the end of by the end of the surgery, as I'm trying to clean the cortex, I might have caught some vitreous strands as I continue that cleaning, and then there I clip the iris to the anterior, the lens to the anterior capsular margin, and there I've got a round, and I do a bit of anterior vitrectomy, and then the surest test, I just put a blob of air there to see that the air is well formed, and that is one of the good tests you can do instead of putting triamcinolone. This is the second case when I'm doing my last case of bimanual IA. As you can see, as I'm trying to get those is there and that side, and there I realized that probably I have a rupture there, as you can see very well. You can see there, yes, there it is. Now this is not totally halfway as Partha has shown or Chitra has shown. See, this is the margin which is already everted there, so there can be, but this is a sign. Now earlier, if you have noticed that the margins were clear, here the margins are everted, so that's a sign that there is a little bit of vitreous popping out there. So I continue there. My option of putting, as you can see there, the vitreous is popping out there, but the anterior vitreous phase is okay. But since the margin is everted there, I'm not sure whether I should go in with a single piece lens within the bag or the sulcus. Now I thought it's better I put a bit of, as you can see, I'm trying to get that bag filled up. I can still see this is not halfway. I put a bit of my good friend viscode there, and then I just plug it there, and then I decide, well, let me put a lens in the sulcus, and the best possible that I think is the sensor lens, because it has got an anterior curved surface, and that helps in a long term. Now look at the way how the lens is put in, so it should be gradual. The pronation and supination of the hand should be right enough. At the same time, don't lose your anterior chamber at this position. If you try to dial it from the side port, and then there you have got, yes, the lens is now stuck in the anterior lens capsule, and there you have got it there the right way. I need not do a anterior vitrectomy there. I have checked it, and then put best in these sort of cases, put a bit of pilocarpine and see the pupil comes down. And this is the next case. As you can see, this IOP, the rhexis is so important in all cases. That's why, in case you go one, other than giving you the shrink wrap effect, that central round rhexis 5.5 millimeter will definitely help you in keeping the lens if you want to put it in the sulcus, so IOL capture can be done. See, this is where I caught it, by vacuum was too high, and there you can see this lens, and as I'm trying to put this a single piece hydrophobic lens. Now look at this is a single piece design. See, as I put it, the lens goes in, and I realize that I have got a rupture here. My capsule, by this haptic, has gone into the bag, and I've got a rupture here. And this is a peculiar design, or see the lens I'll be using, that's got two flange or wings by the side. Now this is a bit tougher than the normal, the Rayner that you get, hydrophilic lens. Now this is a bit tougher, and see that I put it there, and this is the position. I've got an almost oblique rupture there. This haptic is in the bag, and this haptic is still outside the bag in the sulcus. So there I put in viscoelastic from the side. Now I've kept it the way it is. The IOP is 60, just to keep the pressure down, and then little of viscoelastic both behind and in front of the lens, and then gradually tuck this in the bag there, and use these flanges. Bring these flanges in front of your anterior axis margin, so you have two haptics going into the bag and two flanges coming outside the bag over the anterior capsule margin, and there you have got it. See, that's it, and you have got a combination of lens in the bag and lens, part of the lens in the sulcus, the haptic in the sulcus. The last case again, this second last case again, how to get your IOL capture. Just push it there. You will have to get it in the oval shape. Now look at this. This is the oval anterior capsule. Once the two haptics are there, and this is the right way to get it, well round center and oval. And the last case, this was a traumatic, I know this is a history of trauma, a 8-year-old boy. As you can see, there's a history of trauma here. I don't know whether there's a posterior capsular rupture also, but this is how the patient came in. As you can see, here I go, it crosses that, and see there is a bit of fibrosis there. And then as I go forward and front, do a bit of, with the visco, I try to clear that, and this is in the fast forward phase, a little bit of hydro. And then as I go to my bimanual, since this was up there, I can see a big rupture there, and there I clear up as much as cortex from the periphery. Remember that this is a 6-month-old this penetrating injury, so I would expect that the posterior capsule, whichever was ruptured, is already fibrosed by the side. So in this sort of case, generally I would wait for some time till the fibrosis sets in. As I'm trying to clear up the cortex, I know I'm catching up some of the vitreous strands, so there I'm forming the bag, and then continue with the anterior vitrectomy, take out a little bit of whatever vitreous strands that are there. I have not used still the triamcinolone, but I try to increase that posterior opening also, and then put in the lens in the sulcus. As you can see, the lens, the way you have to put it, pronate it. See that at this point of time, the whole anterior chamber is well maintained, so that you don't lose the chamber on the whatever vitreous that might come forward. Once that is done, I've got captured the IOL in the anterior axis margin. Once that is done, I do put in a bit of triamcinolone, and then this is the triamcinolone, and then continue with the anterior vitrectomy, and see that the pupil comes down, whatever little strands that are there, I can see, and that's it. Thank you for your patient hearing. Thank you.
Thank you, sir, for some lovely illustrative videos. 2-3 key points that we must remember is we saw how the capsule got captured in the port. Remember, when you do capture the capsule, don't move the port around. You must be familiar with the reflux button. If you're using a new machine, the foot pedal yaws and gives you a reflux. So even if you've caught the capsule and you just don't pull on it, when you're suddenly jerking, you can obviously reposit the capsule back without a PC rent. Another thing you must be familiar is the vitrectomy settings. All of us must be familiar with what vitrectomy settings we use. We normally use the highest cut rate that is possible on the vitrectomy machine. The infusion has to be put into parallel to the plane of the iris, and your infusion is directed for the anterior chamber. But when you're doing vitrectomy, you have to go deeper. So vitrectomy is posterior directed, but infusion should not be posterior directed. You don't want to hydrate the vitreous. So any other comments or questions?